Okay, well, let's go ahead and get started. I'm David Schwartz, Chair of Medicine. It's a pleasure to welcome all of you to Medical Grand Rounds today. I just want to alert you that in the chat box is the connection to the website to obtain CME credit for this talk. And also, when you have a question during the lecture today, please put your questions in the Q&A folder at the bottom of your screen. We'll sort through them and I'll moderate the discussion at the end of Medical Grand Rounds. It's a pleasure for me today to introduce Lauren Fishbein to you. I've actually been looking forward to this lecture for at least 5 years. Dr. Fishbein is an associate professor of medicine in our division of endocrinology, metabolism, and diabetes. She received her bachelor's degree from Vassar in biochemistry with honors. She also went on to obtain an MD and a PhD degree from the University of Florida. Subsequent to that, she received a master's in translational research from the University of Pennsylvania. Her clinical training was as a house officer at Beth Israel Deaconess Medical Center in Boston, and she did her fellowship training in endocrinology at the University of Pennsylvania. Dr. Fishbein's research has focused on understanding the genetics and the epigenetics of complex diseases such as neurofibromatosis and paraganglioma pheochromocytoma syndrome, She has been supported by the NIH for the past decade to do this research. And she's played an important role in the endocrinology division and in the division of biomedical informatics and personalized medicine in helping others develop their research in understanding the genetics and epigenetics of complex diseases. The subject of her grand rounds today is secondary hypertension when hormones run amok. So please join me in welcoming Dr. Fishbein.
Thank you so much for that kind introduction, and thank you for the invitation to speak today. I wanted to talk about a topic that is very important and near and dear to my endocrine clinical side, which is the secondary hypertension. And there we go. I have no conflicts of interest. And the objectives for today are to list the causes and understand the secondary hypertension, especially those for endocrine hypertension. And then think about the most common form, which is primary aldosteronism, and who should be screened and how should they be screened. And then we'll briefly talk about the workup for some other endocrine causes of secondary hypertension. So let's start with a case. This is a 52-year-old woman with hypertension, and that hypertension was diagnosed around age 38. She didn't start any medications for about 2 more years and then was started on lisinopril. And she took that for many years, but the blood pressure control started to worsen. And recently she was seen in the emergency department for hypertensive urgency and hypokalemia. Currently she takes lisinopril 40 milligrams daily, atenolol 50 milligrams daily, amlodipine 10 milligrams daily. And her blood pressure is still not well controlled, and it ranges from 130 to 150 over 80s to 90s. Serum potassium has been ranging from 3.2 to 3.6. So some questions are brought up by this case here. And the first that I think about is, when should this person have had a workup for secondary hypertension? What are the endocrine causes of secondary hypertension? And given that hypokalemia, you might be thinking about primary aldosteronism. So does this person have that, and how should we screen for it? So let's start with just the prevalence of overall hypertension in the US. These next couple graphs are from the CDC, and it's data from 2015 and 2016. This one's looking at prevalence of hypertension in adults by sex and age. And what you can see is that in people 60 or over 50%, even over 60% have hypertension. And even in the lower age group, the young adults, 18 to 39, there's still a 5 to almost 10% prevalence of hypertension, even in this younger group. And if we separate these out by race and ethnicity, what you can see is that non-Hispanic Blacks have the highest prevalence of hypertension. And this really, as you all know, is due to a lot of factors, and we can't exclude systemic racism as one of them. And we as medical providers need to be aware of this and do better. If we look at the prevalence of controlled hypertension in adults and separate by men and women, what you can see is that only about 50% on average of people with hypertension have controlled hypertension. This is a problem because we know all the downsides and side effects of having uncontrolled hypertension. So we really do need to do better with this. And again, there's a lot of factors that contribute to that need to be worked on. So all the data that I just showed you was from 2015 and 2016. So that was before the most recent American College of Cardiology and American Heart Association task force guidelines on hypertension came out in 2017, 2018. And these guidelines changed the range for stages of hypertension. And instead of stage 1 hypertension starting at 140/90, they now said that stage 1 hypertension starts at 130/80s. So you can imagine the data I showed you is only going to be that much worse if we recategorize hypertension by the current stages. So when we think about hypertension, a lot of it is idiopathic, and in a busy clinic, sometimes we just keep adding medications to control and talk about low salt diet and exercise. But we do need to think about other contributing factors, some of which are medications, and you can see a list here of some common ones that cause high blood pressure. And we need to think about whether we can control the blood pressure with antihypertensives or whether we should work on changing some of these medications that might be contributing to the high blood pressure to begin with. But we're really going to focus this talk on secondary hypertension. So it turns out that about 15% of patients with hypertension have a secondary cause. And in young adults under age 40, that prevalence is even higher, about 30%. And if you look at children under age 18, it's even higher at 50%. And this graphic here is from one particular study as an example out of China, where they looked at over 1,000 patients with hypertension and looked for coexisting conditions. And what you can see in the first pie chart is that obstructive sleep apnea is the most common co-condition associated with hypertension. So need to make sure that our patients are having sleep studies if there's any suspicion for obstructive sleep apnea. The next most common thing really is endocrine hypertension. They labeled in this graph as 18.2%, but you can see that kind of rosy colored pie chart slice that is primary aldosterone with obstructive sleep apnea. So it's really over 30% of the patients in this study that had an endocrine cause for their secondary or associated with their hypertension, I should say. And then if they break down that endocrine hypertension, the 18%, you can again see the most common causes, primary aldosteronism, followed by hypothyroidism, and then pheochromocytoma, or pheo for short, and Cushing's disease and hyperthyroidism. So here's a list of some of the most common causes of secondary hypertension, endocrine and otherwise. And what you can see from this list is in red, the vast majority of the causes are hormone related when there's dysfunction of some sort of hormonal system in our body. And we're going to spend the first part of the talk really talking about primary aldosteronism because it's an under-recognized contributory cause of secondary hypertension, and it's the most common endocrine secondary hypertensive cause. So let's remember our physiology before we jump into the primary aldosterone screening. So this is a schematic of the adrenal glands, happens to be my favorite gland. It starts on the outer edge with the capsule, and then we have the 3 layers of the cortex, the zona glomerulosa, zona fasciculata, and zona reticularis. And then the inner part of the adrenal gland, which is my most favorite, is the adrenal medulla. The adrenal medulla is what makes our epinephrine, our metanephrines, catecholamines. This is where our pheochromocytomas are going to form. The zona reticularis is responsible for making androgens. The zona fasciculata is responsible for glucocorticoids. And it's the zona glomerulosa near the outer edge of the adrenal gland that that expresses aldosterone synthetase and makes our mineralocorticoid, or aldosterone. And aldosterone is released in response to high angiotensin II, high serum potassium, and high ACTH. The ACTH stimulus is a lesser stimulus. The main stimuli are the angiotensin II and the serum potassium levels. Now, we can't talk about aldosterone without talking about renin. And this is a schematic of a nephron, and you can see the afferent arteriole going to the glomerulus and the efferent arteriole. And the filtered substances go down to the proximal tubule, the loop of Henle, wrap up to the distal tubule, and through to the collecting duct. In the afferent arteriole here are our juxtaglomerular cells, and in our distal tubule are our macula densa cells. And renin is released in response to low renal perfusion or low afferent arterial volume, and also to low distal tubule sodium concentrations. And in the opposite direction, renin will be decreased if there's high renal perfusion or high sodium concentration sensed by the juxtaglomerular cells and macula densa, respectively. And once renin is released, it's responsible for converting angiotensinogen to angiotensin 1, and then the ACE enzyme converts angiotensin 1 to angiotensin 2. And then angiotensin 2 will stimulate aldosterone release, as well as will high potassium and to a lesser stimulus, ACTH. Once aldosterone is released, it's responsible for renal sodium retention and potassium excretion and increasing blood volume and renal perfusion pressure. And aldosterone acts on the principal cell of the collecting duct inside the kidney. This is an example of that cell, and aldosterone will go into the cell and bind its mineralocorticoid receptor, which acts as a transcription factor, moves into the nucleus, and stimulates transcription of downstream target genes, which in this case are responsible for transcription and translation of several sodium and potassium channels on the principal cell. And we can take advantage of this to decrease blood pressure, especially in a hyperaldo type state, by using mineralocorticoid antagonists like spironolactone or eplerenone that prevent aldosterone from binding its receptor. We can also use amelioride, which blocks the epithelial sodium channel on the luminal side of the principal cell in the collecting duct. So when there's high aldosterone from any cause, it can contribute to potassium loss and sodium retention, which, as we stated, increases volume and creates high blood pressure. And that high blood pressure, as we know, is responsible for arterial stiffening, causing chronic renal dysfunction, cardiovascular disease, as well as heart disease. And it turns out that high aldosterone itself may have a role in creating fibrosis in the kidney and the heart, in addition to these other effects. So what are some causes of hyperaldosteronism? Well, primary aldosteronism, or Conn syndrome, is the cause we're going to spend the most time on today because it's the endocrine secondary hypertension. But it's important to recognize that patients can have secondary aldosteronism when there's heart failure or cirrhosis. There's also genetic causes of high aldosterone. An example is Little syndrome, which is a mutation in that epithelial sodium channel where amelioride acts. There's also gene rearrangements that can contribute to high aldosterone. And then there's always that board question in endocrinology about licorice ingestion causing a pseudo hyperaldosteronism because of activity of preventing cortisol conversion to cortisone in the kidney. So when we talk about screening tests for primary aldosteronism, really the main tests to think about are serum aldosterone and a plasma renin activity. We use these to calculate our aldosterone-renin ratio. Now, sometimes people will get a direct renin concentration. We usually don't recommend this, but sometimes that's all that's available, and that's okay, but there are caveats. That aldosterone-renin ratio cutoffs are not going to be the same if you use a direct renin concentration as if you use the plasma renin activity. So if you have a choice, plasma renin activity is the lab of choice you want to get with your serum aldosterone. So there are key features to primary aldosteronism. First, you have to have a suppressed renin. This is going to differentiate it from other causes of high aldosterone. And that renin will remain suppressed or have a very blunted response in response to stimuli. And aldosterone will not be suppressed. It will be high. Even in response to stimuli, you can't decrease it. You'll notice that these three key features do not include hypertension and hypokalemia. They're not essential features of primary aldosteronism, but rather dependent features due to the renin suppression and high aldosterone. So many of us in the field of adrenal hypertension think about primary aldosteronism as a spectrum of a syndrome of inappropriate aldosterone secretion that can be mild to overt. So in fact, most patients with primary aldosteronism are normokalemic. Less than a fourth have hypokalemia. And if there's an adrenal adenoma that's aldosterone producing, about half of those patients will have hypokalemia. And again, not all patients will have resistant hypertension. So let's talk about resistant hypertension for a second, because I'm going to show you some studies that involve that. And the definition, just to make sure everyone's on the same page, the true definition of resistant hypertension is blood pressure above a goal despite concurrent use of 3 antihypertensive agents of different classes, one of which should be a diuretic. Or it can be controlled blood pressure, but that requires 4 or more medications for that control. And patients with resistant hypertension are at high risk for adverse cardiovascular events, and they're more likely to have a secondary cause to their hypertension. And that's really important to think about. So this is a study that's quite old. It's from 2006, but I like to show this because it just shows you how long we've known some of this information that we don't always put into practice. So this is a study from 4 different sites around the world looking at subjects who had resistant hypertension. And they showed that the prevalence of primary aldosteronism is about 20% in the population with resistant hypertension. And the same study looked at the prevalence of primary aldosteronism at the different stages of hypertension. Now, because this study is so old, this is using old hypertension guidelines, of course, but it's just to relay the point that you don't have to have resistant hypertension to have primary aldosteronism. You can have primary aldosteronism even at stage 1 hypertension, again, based on the old guidelines. This is a much more current study. It came out just earlier this year by Dr. Vadaya from the Brigham and Women's Hospital. It's actually a multi-center study where they prospectively looked at over 1,000 patients with either untreated normotension, so no high blood pressure, or untreated stage 1 or 2 hypertension with the current hypertension guidelines, and a group with resistant hypertension. And on this demographics table, one of the things that I wanted to point out was race. They had about 2 to 1 white to black population in their study. And if you look at the resistant hypertension group, I want to point out that there's almost twice as many Black subjects with resistant hypertension as white subjects. And this is important for us to think about. This may have to do with access to care, with other issues of systemic racism that we need to think about and do better as providers, clinicians, and physicians. Okay, so let's talk about what they did in this study. They took the 1,000 patients and they measured a serum aldosterone and a plasma renin activity, no matter which group of category of hypertension or normal tension they had. And then they performed a salt suppression test. This is a test that we normally do for confirmation for primary aldosteronism, but they did this in all subjects where they had them have high salt intake for 4 days and then collect a 24-hour urine for aldosterone and sodium concentration. And this is a graph to show you that if you look at the 24-hour urinary aldosterone excretion, you, as expected, see about half the patients with resistant hypertension having high urine aldosterone concentrations. But what you might not expect is that there's a subset of even normotensive patients who have high urine aldosterone concentration despite the oral salt loading. This is suggestive that primary aldosterone may be occurring even in these normotensive patients, along with the stage 1, 2, and resistant hypertension patients. Now, this is the bulk of their findings. I know it's a complicated table. I'm just going to point out a couple pieces of information. The first is what they calculated as crude prevalence of overt primary aldosteronism based on using the aldo-renin ratio. And here what you can see is that the prevalence of primary aldosterone ranged from 2.4% in the normotensive group to 10.3% in the stage 2 hypertension group and 6.6% in the resistant hypertension group. This is lower than maybe we would expect. And it tells us that our positive predictive value and negative predictive values are not so great for this particular test. Maybe the negative predictive value isn't too bad, but our positive predictive value is certainly not so great. And they suggest that if they use the 24-hour urine aldosterone concentration in response to that oral salt loading test, you will get a more generous, if you will, number for prevalence of overt primary aldosteronism. And you can see that it ranges in prevalence from 9% in the normotensive group, 9% in people without hypertension, up to 24% in those with resistant hypertension. So these authors really propose this schema that there's a spectrum of primary aldosteronism. Normally, we screen for primary aldosteronism in patients with severe hypertension, and they will, to some percentage, have primary aldosteronism. But we have to think about our patients before they have this kind of end organ damage and severe hypertension. What about when they're mildly hypertensive? And what about even these normotensive patients? They may have biochemical primary aldosteronism. And if we can diagnose this sooner, we may be able to decrease their cardiovascular and renal morbidity. So given all these data, who really should be screened for primary aldosterone? Well, let's think about what we typically use for symptoms and signs of when we think about screening for it. It's usually our patients with hypertension and usually those with the resistant hypertension. We think about hypertension with hypokalemia as a big tip-off. And patients may also complain of fatigue and muscle weakness, metabolic alkalosis. But remember, I just showed you the data where you don't have to have severe hypertension or hypokalemia to have biochemical evidence of primary aldosteronism. So we have to think about that when we think about who to screen. So let's start with the Endocrine Society guidelines. These were last updated in 2016. And what the Endocrine Society recommends is that patients who have resistant hypertension, hypertension with hypokalemia, whether that's spontaneous or diuretic-induced hypokalemia, should be screened for primary aldo. Patients who are young, less than 40, patients with hypertension and an adrenal tumor, those with hypertension and sleep apnea, and those with hypertension in first-degree relatives of patients that have known primary aldosteronism. And so these are the recommendations for who to screen based on the Endocrine Society guidelines, again, from 2016. Now, Dr. Bill Young, he's an adrenal guru at the Mayo Clinic. He has suggested for quite some time that all patients with hypertension should be screened at least once for primary aldosteronism. And why does he recommend this? He recommends this because A, it can be easily treatable. B, if you can lateralize which adrenal gland the overproduction of aldosterone is coming from, you can actually cure it in half the cases. Medications will significantly improve the hypertension even if you can't do an adrenalectomy. And there's some evidence from several studies that high aldosterone causes more cardiovascular and renal morbidity, at least partially independent of the effects from blood pressure, and that this excess morbidity can be reversed after treatment. So I don't have time to show you all that data, but I want to show you some of the data from one study that leads to this last point. And that's here. This is a very complicated slide, but I'm going to break it down. This was a retrospective study where they took 400 patients with primary aldosteronism without any pre-existing chronic kidney disease, and they initiated spironolactone or mineralocorticoid antagonist therapy. So primary aldo treated medically. Then there was a group of 120 patients with primary aldo without pre-existing chronic kidney disease, and they were treated with surgical adrenalectomy. And then finally, they looked at a historical group of over 15,000 patients with essential hypertension without pre-existing kidney disease, and they matched them by age and baseline GFR to the primary aldo cohort. And what they found was here. So the blood pressure of all three groups was pretty equally matched. And they saw that whether they looked at the incidence of chronic kidney disease or the GFR, Those that did best were those who had primary aldo treated with surgery. That's the green line here. They had less incidence of chronic kidney disease and better GFR over time compared to those with essential hypertension or those with primary aldo treated medically. And that may be because those treated medically were chosen not to have surgery for some reason because they already had more morbidity associated with whatever their comorbidities were. It could be that that these patients also had worsening or a longer disease, or it could be the effect of that high aldosterone causing fibrosis, which is a separate effect than the blood pressure effect from aldosterone. Now, there's sort of a third vision of how to screen patients for primary aldo. This is a paper that just came out last month, so it's not indexed yet, but it's accepted online at JCEM by Dr. Vidaya from Brigham and Women's and Dr. Carey at University of Virginia. And they suggest that we should screen everyone according to the Endocrine Society guidelines, but include those with at least stage 2 hypertension. So they don't go as far as Dr. Young to say everyone with high blood pressure, but at least those with blood pressure over 140/90, regardless of their control, regardless of the number of medications or comorbidities. So as you can see, there's huge debate in the field about who we should screen as a case detection for primary aldosteronism. But there's also a debate on how to diagnose what are the cutoff levels for aldosterone and plasma renin activity. So some say, and the guidelines actually say, that an aldo greater than 15 and a PRA less than 0.6 should be used. But some say an aldo over 10, it could be a cutoff, and a PRA less than 1 could be a cutoff. And there are cases we all know of aldosterones even less than 10 that are associated with primary aldosteronism. And the ratios are also controversial, whether the aldosterone renin ratio should be greater than 20 or greater than 30. So I think this is one of the impediments for why people don't screen for this more often. Aside from just thinking about it, it's also hard to know how to interpret the results once you get them. It's also hard to even do the testing. So this is a very complicated algorithm that's proposed for how we should do this testing. And it's taken really from the Endocrine Society guidelines, but from a review written by Dr. Bird. Patients have to have liberal salt intake. The labs are supposed to be drawn in the morning with the patient sitting upright about 2 hours after they woke up. They have to have normal potassium. You have to stop certain interfering medications for 2 weeks and mineralocorticoid antagonists for 4 weeks, and then follow this complicated algorithm with different cutoffs depending by different labs that you test. Well, this is clearly very complicated and probably another reason why patients aren't screened appropriately. Even if people think about primary aldo, they may not be able to get the patients to come back to do the testing in this way. Patients may not have enough access to care or have enough money to come back that many times and change their medications around. So these are all important things to think about. If we think primary aldo is a really important cause of secondary hypertension, which I would argue it is, we want to be screening more people for this so that we can hopefully cure them and treat them to the best of our ability. So other algorithms have been proposed, and this is from that paper that just came out from Dr. Vidaya and Carey, but this really is what I have been doing, and probably many of my colleagues with adrenal expertise and secondary hypertension expertise in the field have been doing. So we recommend that, and Dr. Vidaya and Carey recommend, that we check plasma renin activity and aldosterone in all patients when they're in your office. No matter what medications they're on, no matter what time of day, just check it while they're there. And the reason for that is because if it comes back with a non-suppressed renin, regardless of their medications or time of day, this is very unlikely to be primary aldosteronism. And even if the renin is suppressed, but the aldo is less than 5, again, unlikely to be primary aldosteronism. Now, if your pretest probability is very high, but you fall in this category, then you can bring the patient back, change some medications around, try to do it the right way, and see if you get a different result. The other thing to consider is that if it's not primary aldo, these patients may also be responsive to mineralocorticoid antagonist therapy. And there's data to show this, that these patients can do better even without primary aldo, and adding spironolactone as a fourth-line agent in resistant hypertension can be very helpful. Now, if we look at the other side of the algorithm, when renin is suppressed and aldosterone is over 15, this is an overtly positive screen, again, regardless of the medications or time of day. And if that potassium is low, in addition to the aldo being high and the renin being suppressed, you've basically confirmed overt primary aldosteronism. And these patients should be referred to a specialist for further evaluation with adrenal vein sampling, imaging, and subsequent treatment. Now, if there's no access to specialists at that point, even with an overtly positive screen, go ahead and empirically start mineralocorticoid antagonists. Or if patients are not surgical candidates or don't want surgery, go ahead and start mineralocorticoid antagonist therapy. In the center group, if the aldosterone falls in between 5 and 15, this is still considered a positive screen, and more testing needs to be done to confirm a primary aldosterone. And we would suggest at this point to refer again to a specialist, either a nephrologist with expertise in secondary hypertension or an endocrinologist, to do some more confirmatory testing. And again, if that can't be done or there's no access, empirically start mineralocorticoid therapy to help these patients. Now, thinking about the algorithm that way doesn't negate the fact that there are some things that cause false positive and false negatives in this screening test for a primary aldo. The false positives, though, are very rare. The main one is renal dysfunction or hyperkalemia, because that's going to stimulate aldosterone production. So this doesn't work very well in patients who have end-stage renal disease. But the other things that cause false positives aren't really used very much, whereas oral contraceptives may be used a lot, but they affect the direct renin concentration, not the plasma renin activity. So it's really that false negative group we have to be aware of. So again, if your pretest probability is high, but your results initially fall in that false negative group, that's when you might want to look at things in a little more detail and change some medications around. Mineralocorticoid receptor antagonists and ACE inhibitors and ARBs will affect that renin and aldosterone, and we want to be careful and may have to change around medications there. But again, your initial screen, if positive, is most likely going to be positive. It's if it's negative, but your suspicion is high, that you want to go in and do some further testing. If you do have to change medications around, this is a list of the medications that have minimal effect on the aldosterone-renin ratio. And that includes verapamil, hydralazine, and what I call the Zosins, the alpha-adrenergic blockers. Now, I don't have time in this talk to go into detail about the familial inherited genetics, but I just want to mention familial hyperaldosteronism does exist. There are chimeric genes that can form and be inherited. There are mutations in potassium and sodium channels. And I'll just point out this last one. Patients who have bilateral macronodular adrenal hyperplasia on CT or MRI imaging may have ARMC5 mutations. And this can be important because these patients will have continued hypertension despite debulking on one side. And if they do have this germline mutation, their family members should be checked so they can be diagnosed and treated early. So let's go back to that case, the uncontrolled hypertension on 3 medications with hypokalemia. When should this person have had a workup for secondary hypertension? They should have had it at age 38. They're under 40 with hypertension. We need to think about secondary workup. And then what are the endocrine causes? I think we went through those. And this person, do they have primary aldosteronism, and how would we screen? So it is likely that uncontrolled hypertension started at a young age and has hypokalemia. So in fact, if we replace the potassium to make it normal, the aldosterone for this patient was 9, the plasma renin activity was suppressed at 0.38, and that takes your ratio to 24. So this could be primary aldosteronism. It probably is, and they should be referred to a specialist. And after doing a salt suppression test, we measure this 24-hour urine sodium to ensure they took in enough salt, and we can see that the urine aldo was not suppressed as it should be. This confirms primary aldo. This patient should have adrenal vein sampling, and if there's lateralization, then adrenalectomy. All right, let's talk about case 2. Case 2 is actually very similar to case 1, you'll notice, except this person doesn't have hypokalemia. So what if you had a 52-year-old woman with hypertension, diagnosed at age 38, now coming in with hypertensive urgency on 3 medications and not well controlled? We're of course gonna think about primary aldosteronism, but what else do we need to think about in this patient and screen for? So I'll remind you about the causes of secondary hypertension. We talked endocrine especially. We talked about primary aldosteronism. There's also hypothyroidism and hyperthyroidism. These can easily be screened with a TSH, and I'm not going to talk more about that. But let's spend a minute talking about pheochromocytoma, paraganglioma, and Cushing's disease. So as Dr. Schwartz mentioned, pheochromocytoma, paraganglioma are near and dear to my heart. My research program currently really focuses on this tumor, and I'll show you in a little bit why I find it so fascinating. So I just wanted to take a second to talk about a famous person with pheochromocytoma that's related to University of Colorado. And since you all can't answer me and shout it out, I'm going to tell you that that's President Eisenhower. So he was at Fitzsimmons Hospital during his presidency for months with congestive heart failure. So the story goes, he actually probably had a pheochromocytoma that contributed to that congestive heart failure. All right, so the clinical presentation that we learn about in textbooks for pheochromocytoma, paraganglioma is the classic triad of headaches, palpitations, and sweating. And most patients have hypertension, but that hypertension can be sustained or orthostatic or episodic or relative. And many patients have other symptoms besides that classic triad, and they may not even have that classic triad. A lot of patients can even be asymptomatic and still have a pheochromocytoma. So pheos and paras are neuroendocrine tumors of the adrenal medulla and sympathetic and parasympathetic ganglia from the skull base all the way to the pelvis. Approximately 25% of them become metastatic, defined by distant spread. And probably a lot of us learned in medical school that this is the tumor of tens. But this is an old dogma, and hopefully the medical students, interns, and residents on the talk today have not learned this. Hopefully they've learned more updated knowledge, which is that 20% of pheos and paras are extra-adrenal, up to 25% can be metastatic, up to 55% can be asymptomatic, and up to 40% can be hereditary. And in children, this number is even higher, where up to 80% can be hereditary. It turns out there are now over 12 susceptibility genes for pheo and para. It used to be the rule of 10 because we only knew 3 conditions: neurofibromatosis type 1, multiple endocrine neoplasia type 2, and von Hippel-Lindau disease that predisposed to pheo-para. But in the last 2 decades, we've identified many more genes and related syndromes that can predispose to developing pheochromocytoma and paraganglioma. And these genes are located in a variety of different pathways in the cell. And this is what got me studying pheochromocytoma and paraganglioma. It's such a wide variety of mutations in different pathways that lead to the same tumor. And it makes studying the inherited and somatic genetics of these tumors quite fascinating. And pheochromocytoma paraganglioma is the solid tumor with the highest hereditary component. Okay, enough of that soapbox. Let's get back to the clinical situation. How do we differentiate between sporadic and hereditary pheos and paras? Well, we can think about those with young age, family history, extra-adrenal tumors, multifocal tumors as being more likely to be hereditary. However, if you put data together from lots of different studies, up to 25% of people with an adrenal pheo without a family history still have a hereditary cause. About half of the head and neck paragangliomas are hereditary. About half of the metastatic pheoparas are hereditary. So this suggests that, and we recommend that all patients with pheopara should be offered clinical genetic testing because it helps screen them and their family members. Okay, let's talk about the screening test if you're thinking about it. It used to be that the gold standard was 24-hour urine metanephrines and catecholamines. But now with liquid chromatography mass spec, plasma metanephrines are much easier and just as sensitive and specific, really, as the 24-hour urines. Now, the guidelines do recommend that you screen with plasma metanephrines in a supine position for 30 minutes before the blood draw. That's not easy to do, and that's going to inhibit people from screening. So I just do it sitting up. If you are negative and you are in the seated position, that is likely to be negative. It's the false positives in the seated position that are of concern. But what I have found is that more false positives come from interfering medications than they do from the seated versus supine position. There are a lot of medications that can interfere. So stop them if you can, but if you can't, still just test the patient. If it's negative, they didn't interfere and it's a negative test. If it's positive in any way, refer to endocrinology and we'll help finish up that evaluation. So if we think about that patient with uncontrolled blood pressure, what if we wanted to screen for pheopera? Well, let's say we did and the results came back with plasma metanephrine and norepinephrine being quite high, refer to endocrinology. And I'll just do another key point is that often if we look back, these patients have had some sort of CAT scan earlier than age 52 in their lives. And you can sometimes see an adrenal nodule years ago that wasn't paid attention to in terms of the adrenal incidentalloma workup. And this could be a pheochromocytoma that needs treatment. Okay, well, let's go back to that exact same case and think about what else we should be screening for. And I'll just spend the last couple minutes talking about Cushing's disease and Cushing's syndrome. Cushing's disease or Cushing's syndrome is a glucocorticoid excess, and that can be ACTH dependent or independent or iatrogenic. When we say ACTH dependent, we're talking about pituitary adenomas and ectopic ACTH production. When we talk about ACTH independent, we're talking about adrenal causes, adrenocortical adenomas or carcinomas, or nodular adrenal hyperplasia. And then if you're just thinking about patients who look Cushionoid, the most common cause of that is actually exogenous glucocorticoid use. So you really need to ask about all possible types of steroid they may have been exposed to. So what are the signs and symptoms of Cushing's besides hypertension? Well, patients can have hirsutism, a red round face, acne, easy bruising, weight gain, especially central obesity, purple thick striae on the abdomen or inner thighs, supraclavicular dorsal cervical fat pads, proximal muscle weakness, abnormal menses, and patients can have new onset or worsening diabetes, hypertension, or osteoporosis. The complicated thing about Cushing's is that there can be minimal signs and symptoms if there's mild autonomous cortisol secretion, especially from a benign adrenal adenoma or hyperplasia. So the best way we recommend screening for hypercortisolism, to start with at least, is a 1 milligram dexamethasone suppression test. And the reason we suggest this is to remember your HPA axis. The hypothalamus secretes CRH to the anterior pituitary, which secretes ACTH and stimulates the adrenal glands to make cortisol, which provides negative feedback. If you give a high dose steroid around 11 p.m. or midnight, you're going to turn off this axis and blunt or prevent the cortisol surge in the morning with the circadian rhythm. So a dex suppression test should show a morning cortisol less than 1.8 if it's normal. If it's abnormal, refer to endocrinology and we can do further workup to decide the etiology. Is it ACTH dependent, independent, or ectopic? And I don't have time today to talk about this, but I just wanted to mention that those are the next steps. So if we look at this case, let's say we did a 1 milligram dex suppression test and the morning cortisol was 5, that's certainly higher than 1.8. The CT scan shows an adrenal nodule, and the endocrinologist will check that baseline ACTH, which is low, suggesting this is an ACTH-independent hypercortisolism. Cortisol is high, and the 24-hour urinary free cortisol is elevated. This suggests an adrenal source, and this patient needs an adrenalectomy for that adrenal nodule. So hopefully I've impressed upon you today the importance of thinking about secondary hypertension, because it can be so prevalent in lots of populations. And we really need to think about secondary causes and test for them in a lot of our patients, especially those with uncontrolled hypertension, hypertension and another comorbidity, and maybe even all patients with hypertension. And here are some things to think about for not just the endocrine causes, but the other causes of secondary hypertension as well. So thank you very much for your attention, and I want to leave the last 15 minutes for any questions or discussion. Thank you.
That was terrific, Lauren, Dr. Fishbein. I really appreciate you presenting such a complex series of diseases that are important in terms of taking care of our patients with hypertension. There are a number of questions that have come in. Let's take the first few questions related to hyperaldosteronism. Tell us why patients, only 50% of the patients have decreased potassium.
Oh, good question. So it has to do with that spectrum. So remember that the decreased potassium is coming from high aldosterone, really. And if the aldosterone is so high, it's going to cause hypokalemia. But because there's a spectrum in primary aldosteronism, not everyone reaches sort of that critical mass where the potassium can't be still controlled. And so that's the reason for it. So in cases where there is bilateral adrenal nodular hyperplasia, sometimes the primary aldo is not as high, and so the potassium might not be as low. But in cases with an adrenal nodule that's over making aldosterone, then it increases to half the patients will have it because it's probably been there longer, the nodule's growing, making even more aldosterone. Good.
Given the high prevalence of primary hyperaldo in the Brigham report, should mineralocorticoid receptor antagonists be used as a first-line therapy for patients?
There's a lot of discussion in the field about that, and I don't think everyone agrees on that yet, but most of the studies and most of the algorithms have adding it to a fourth line therapy when you're talking about resistant hypertension. And I think many of us would argue that perhaps it should be at least moved up sooner and not just a fourth line therapy. I don't know if it should always be first line if you haven't diagnosed primary aldo, because it's not always a very good antihypertensive for other causes of hypertension. But I certainly think it could potentially be moved up and not always be fourth or fifth line therapy.
Okay, very good. And what about the relationship between sleep apnea and hyperaldo? What's the physiologic connection?
Yeah, so there's lots of hypotheses for this. One of them is that the obstructive sleep apnea increases sympathetic activation from the sympathetic nervous system. That will trigger more release in the adrenal gland of epinephrine, and some of that will stimulate cortisol secretion through various methods, and trigger the whole axis, that it can be a stressor with even the hypoxia, triggering then CRH to release ACTH, and ACTH, even though it's a lesser stimuli, is a stimuli for aldosterone as well. So there's lots of potential reasons. I'm not sure anyone knows precisely why. These are all kind of theories about why.
And while we're talking about, the effect of other organs on aldosterone, what about the effect of aldosterone on other organs? In other words, the fibrosis connection that you brought up. Tell us how that occurs and how extensive the fibrosis is, where it's located.
Yeah, so it's been primarily studied in the heart and the kidney, where they've seen fibrosis in patients who have high aldosterone levels. And this part is not my area of expertise, so I'll say that first. My understanding is that in any condition that raises aldosterone, so even if it's a secondary aldosteronism, it doesn't have to be primary, but there's high aldo, it is associated with seeing that fibrosis in the organs. The mechanism for how that happens, I'm not sure people fully understand. There's some other genes that may be regulated through transcription over long courses of time that contribute to it, but I don't know the exact mechanism. I'm not sure people do, but that's something that I could look up more and get back about.
Good. Since young women are at risk of hyperaldo and also are of childbearing age. Given the teratogenic effects of spironolactone, tell us how you approach that decision and that population.
Yeah, that's a good question. So this goes to a point which I didn't talk about a lot, which is the subtypes of primary aldosteronism. And I think I may even have a slide here for this. Let me see. I saved some extra slides just in case there were some questions.
Terrific.
And we're gonna skip these. Here we go. So these are the different subtypes of primary aldosteronism. So you can see the most common subtype is actually bilateral idiopathic hyperplasia. About 60% of the cases will have that. And so they can't be cured by adrenalectomy. But about 30% of the cases are going to have a unilateral aldosterone producing adenoma in the adrenal glands. And then there are a smaller number of cases who have the genetic causes. So what I would say is that it's very important to determine what the subtype is, because that's going to direct therapy. So for young women in particular, if they have a lateralization and unilateral production of aldosterone, which we determine by doing adrenal vein sampling, then surgery will cure them and they won't have to be on spironolactone. So I would say that would be my first choice in dealing with women of reproductive age, if we can do it that way. If it's an issue of the person having a bilateral idiopathic hyperplasia or one of these other causes that can't be cured by surgery, then that becomes a little bit more tricky. And we may have to think about using other medications in the short term to try to control their blood pressure. It also will be how out of control is their blood pressure, because remember, some people with primary aldo don't have out of control resistant hypertension, and you can control it on one or two meds. It depends where on the spectrum they are. So I think we'd really have to individualize care in that way.
So while you're focused on the subtypes of hyperaldo, are there different subtypes of hyperaldo that are associated with the ethnic prevalence of this disease? Is primary hyperaldo more common among Blacks? What's the distribution?
Yeah, I'm not sure anyone knows for the prevalence of primary aldosteronism. I don't think I've seen anything about differences there. However, there's a lot of work in looking at somatic mutations within the aldosterone producing adenomas, both germline and somatic mutations that seem, or even just variants in certain genes that are these potassium and sodium channels that vary based on ethnicity. So Bill Rainey out of Michigan has been leading a lot of these studies, and they've shown that there's a different set of mutations in these aldosterone producing adenomas in Blacks compared to white populations. And there's some work now just coming out about some Asian populations as well. So I think there'll be more to learn about this in the next couple years. They're just starting to see these differences in some of the gene variants within the adenomas.
So there was some concern about well, let me just ask a follow-up question related to that. So it's more than just access to care. And what are the other features besides genetics and access to care that we should think about?
You in diagnosing, or why there's a difference in the rates of resistant hypertension and things like that? Yeah. I think there's so much that goes into it. So diet is going to be another one. So heavy salt diets, economic status is going to be one, because lower economic status usually means eating less or more high salt food, whether that's fast food or frozen meals that are pre-prepared. And especially in primary aldosteronism, there's a huge amount of salt sensitivity to how your blood pressure is controlled. So I think that plays a role. I do think genetics is going to play a role, and I do think that personalized aspect will come into play. We're just not quite there yet, but we are getting there. And I think that that will help us as more and more people are having their genome sequenced and being genotyped. I think we'll have more access to that and see also who responds to which medical treatments. We know, for example, that beta blockers have different activity in people with different ethnic and racial backgrounds. And I think the more we learn about why that is and how that works, the better we'll be able to treat patients. The other thing I think is bias within providers. There's a lot of data just to show about how we listen to patients in our office and how we deal with treating blood pressure and giving medications without explaining why and the cost of getting these medications. And I think all of this plays a role into why there may be differences in resistant hypertension treatment and control.
Good. There were a couple of questions that related to the toxicity of a salt suppression test. What are the alternative tests that you would consider, and do you favor, or why do you favor a salt suppression test?
Yeah, this is a great question. So what I would say is that I usually do not do confirmatory testing. And that's because we can usually tell if this is going to be primary aldosteronism based on the serum aldosterone and plasma renin activity alone. By using that algorithm, you can usually make the diagnosis, even without changing medications around. But sometimes you change medications around, you should still make the diagnosis that way. So there are very few cases where I have to do confirmatory testing before I move to adrenal vein sampling. When we do have to do confirmatory testing, the one that I prefer, to be honest, is the saline suppression test, where you bring the patient into the infusion clinic to do it, rather than the oral salt suppression test that patients do at home. The reason for that is the home test is easier, absolutely. It costs less money, absolutely. But if the patient has resistant hypertension, any sign of congestive heart failure, you can put them into acute heart failure with a 4-day salt load at home. So if you do the oral suppression test at home, you need to be very careful about that, checking in with the patient. They need to know if they start gaining weight, which should be fluid from all the salt, that they're getting help, that they're careful about having shortness of breath, and they're checking their blood pressures at home over the 4 days they have to salt load. So that's why I prefer the saline suppression test, where you bring the patient in and you run a few liters of saline while they're being observed, blood pressures taken, and you measure aldosterone and renin concentrations in the blood at various time points. And I prefer that test because the patient's being watched and monitored, and you can always give a diuretic afterwards to get the fluid off. There are a few other tests, a fludrocortisone test, captopril test. We don't tend to really do those. I would say that either the oral salt suppression test at home or the saline suppression test in the infusion center are going to be your most common confirmation tests that we do, at least in the US. But again, I do those rarely. Usually you can move straight to AVS based on the screening test alone.
Good, great. Do you tell us a little bit about this old hypothesis, the Larrick hypothesis, that low renin is important in terms of essential hypertension in the elderly and in Blacks, and is a form of hyperaldo?
So meaning that sometimes you can see a low renin. The difference is that, in my understanding, the difference is that the renin doesn't tend to be as low, so it's not fully suppressed to that below 0.6 state, and or it is still responsive to stimuli in those situations. So renin may be low, but if you provide a stimulus that should raise renin, you should be able to see that activation. So that's my understanding of how you would differentiate that.
Okay. Tell us about Dopplers and versus CT scans in terms of diagnostic approaches.
For like renal artery stenosis, or for adrenal adenomas? For both. Okay. So if you're looking for adrenal adenomas, most of the time we want to get a CAT scan rather than an ultrasound. There's a couple reasons for that. And I have them here. So on a CAT scan, on a non-contrast CAT scan, you can use the Hansfield units of the adrenal nodule to let you know if this is a benign nodule or something more worrisome. So Hansfield units are an arbitrary measurement of density on a CAT scan. And so Hansfield unit of 0 is based on water. So things that are fatty are going to have low Hansfield units. And you can imagine that the adrenal cortex is made up of a lot of hormones that are derived from cholesterol. Cholesterol is a type of fat. An adrenal cortical adenoma, a benign adenoma, should have low Hansfield units, less than 10. And so when you're comparing adrenal nodules, you can use the Hansfield units to differentiate what they are. And so Hansfield units less than 10 are usually benign adrenal nodules, and they may be secreting or not, but they're at least benign. Whereas Hansfield units greater than 10 could be a pheochromocytoma or an adrenal cortical carcinoma. And so a CAT scan will tell you more than an ultrasound. Also, ultrasounds for adrenal nodules can be tricky in those that are overweight in order to be able to get enough penetration to see. For the renal artery stenosis, that's usually where you want the Doppler. So you want a renal ultrasound with Doppler to see the blood flow there.
Okay, that's terrific. I don't know if you have any final comments you'd like to make.
Just to point out that, these can be really complicated to interpret results for both primary aldo as well as pheo and Cushing's. And so just don't hesitate to initiate endocrine consults, but think about it and start that screening process. I think that's really important, not to wait so that patients get lost to follow up, but to start the process while they're there with you.
Thanks so much. This has been an incredibly informative lecture.
Great. Thanks for having me. Thanks everyone for your attention.